Many data point to excessive cholesterol-containing lipoprotein particles as an important trigger to inflammation in atherosclerosis. LDL particles, particularly when modified by oxidation or after conjugation with glucose, can instigate inflammation. When LDL accumulates in the artery wall, the modified lipoprotein particles can inflame the endothelial lining, eliciting the expression of adhesion molecules that cause blood leukocytes to attach to the endothelium. Modified LDL also stimulates production of chemoattractant cytokines that call the adherent leukocytes into the artery wall. Other cytokines stimulate the white blood cells now resident in the intima, provoking them to mature into macrophages and to release further inflammatory mediators, including reactive oxygen species that cause local oxidative stress. Uptake of modified LDL by macrophages creates the foam cells characteristic of an atherosclerotic plaque. Growth factors and cytokines stimulate smooth muscle cell migration from the media into the intima, where they can proliferate and lay down extracellular matrix molecules such as collagen. Thus, inflammation regulates the initiation and the progression of atherosclerotic plaques. Inflammatory mediators augment the thrombogenicity of the plaque and blood and thereby promote thrombotic complications of atherosclerosis. For example, inflammatory cytokines can increase expression of a potent procoagulant known as tissue factor, the most important trigger for thrombosis in the plaque. Activated macrophages secrete enzymes that break down collagen, the protein that lends strength to the plaque's fibrous cap. When a weakened plaque ruptures, the abundant tissue factor uncovered can cause thrombi to form. Occlusive thrombi can cause acute myocardial infarction or may embolize to cause strokes. The role of inflammation in the pathogenesis of atherosclerosis has important clinical implications. Is there a practical way to measure the link between inflammation and the atherosclerotic process? Recently, renewed interest has burgeoned in measurement of C-reactive protein, or CRP, in peripheral blood as a clinically useful marker of inflammation in the context of atherosclerosis. CRP predicts risk for future cardiovascular events in apparently well men and women, even when LDL levels are below average. Where does CRP come from? Inflammatory stimuli, such as modified LDL, can provoke local release of inflammatory mediators from arterial wall cells. The primary inflammatory cytokines, interleukin-1 or tumor necrosis factor alpha, can stimulate production of a second wave of cytokines that amplifies the inflammatory response. This second wave of cytokines includes the important messenger interleukin-6. IL-6 can travel through the bloodstream to the liver, where it instructs hepatocytes to boost the production of a set of proteins known as acute phase reactants, which typically rise to high levels in acute illness. CRP is one such acute phase reactant. Research has revealed that in apparently healthy people, slight elevations of CRP within the normal range, measured with a high-sensitivity assay, hsCRP, seem to indicate subtle or smoldering forms of inflammation somewhere in the body. Thus, hsCRP sensitively indicates inflammation. CRP has particular utility as a marker of inflammation because of its exceptional stability and ease of accurate measurement with an inexpensive assay. Also, CRP levels fluctuate little during the day or from day to day in a person unless they have an acute illness. Analyses of data from multiple large clinical studies have shown that people with CRP levels only slightly above average have a much greater risk of complications of atherosclerosis, including heart attacks, strokes, or peripheral vascular disease. Indeed, CRP predicts cardiovascular events as well or better than LDL cholesterol. Recent guidelines have established CRP cut points that define the degree of risk for future cardiovascular events. Less than 1, low risk. 1 to 3, moderate, and greater than 3 milligrams per liter, high risk. Does modification of inflammation influence atherosclerosis? In experimental atheromata, HMG-CoA reductase inhibitors, or statins, decrease cytokine levels, limit local leukocyte adhesion molecule expression, lower plaque tissue factor procoagulant, and favor features of plaques that should render them stronger and resistant to rupture. Statins may thus have direct anti-inflammatory properties in addition to LDL reduction. Will lowering CRP by statins reduce cardiovascular risk? Analyses of clinical trials have suggested that statin treatment can reduce cardiovascular events in individuals without apparent heart disease and with below median LDL levels, but above median concentrations of CRP. In fact, patients who have an LDL of less than 130 milligrams per deciliter and a CRP level greater than 3 milligrams per liter represent a high-risk group often missed in clinical practice. A prospective study is underway to test whether statin therapy will reduce events in this patient population. The recognition that inflammation contributes to atherosclerosis has not only broadened our understanding of the mechanisms of this common killer, but may offer new tools to combat heart attack, stroke, and cardiac death.